So we're actually ahead of schedule, which means I can spend the next hour with you to review what we did all day long. So we're going to take the next 5 or 6 minutes as you're filling out your evaluation form. I'm going to just review what we did all day today, okay? So I'm going to talk real fast, and some of it might be wrong, but that's okay. So continue to mark off your evaluation forms, please, because we need those back. So in the morning, we started off with Leonard. He was giving us an expert view sort of over historical times. He said critical lesions is what you're looking for, meaning left main, greater than 50% stenosis, or triple vessel disease, more than 70%. So basically those people, if you intervene with an operation of some sort, you might do better. How might one find those people? So if you do an exercise stress test, if they have a stage 1 positive, they're 90% likelihood of having either left main or triple vessel disease. If their ST segment depression is more than 2.5 millimeters, then it's an 80% chance that they're going to be having a critical lesion. And if they're hypotensive, it's a 100% chance they have a critical lesion. So even though we don't think of exercise stress tests, that could still pick out a lot of patients for us. Don't forget about collecting the risk factors as well. It sort of tells you the soup that the patient is living in. And then he said that when you do an angiogram, no matter what you do, you stare at the stenosis so that you may not make the proper decisions, because what we should do is operate on only the people that will have benefit. He talked about the COURAGE study, which looked at PCI versus intensive medical therapy, and there was no benefit between the two. But then he also clarified that some of the patients were removed from the study. So in other words, it's not exactly every comer. There were people that were selected out, and maybe the people that would have benefited from it were removed from the trial. Medical treatment must continue before, during, and after bypass or any intervention that you do. And that basically angina is a situation where there's an imbalance between oxygen demand and consumption and so on and so forth. So supply and demand, it's very hard to increase supply, so therefore you work on the demand side. He reminded us about Laplace law, about the balloon stretching and the wall being under more tension, therefore you're using more oxygen. So that's why we try to decrease heart rate, decrease blood pressure, decrease weight, and increase exercise, as we talked about yesterday. Then we had PCI folks. So Peter basically said there's 8 simple rules, and I only counted 5 that were good because a couple of them actually repeated themselves. But symptoms, basically PCI is very good at removing symptoms. In terms of prognosis, he said in some cases it'll change the prognosis. So basically he's trying to say, without saying it, that mortality may have benefit in some people, but not in all. But for sure, symptomatic relief will be there. Lifestyle and other medications must also continue on, so similar theme. And that basically you maximize your medical therapy, and only if their symptoms are continuing on, then you consider PCI. In the more severe lesions or multiple site lesions, then he even conceded that PCI may not be the choice and that surgery may actually be a better strategy for you. In the acute setting, basically, if you're having a STEMI or a non-STEMI acute coronary syndrome situation, that the PCI actually does better. Then we had our cardiovascular bypass folks, and basically he said that there is no role for PCI. No, that's not what he said. He said in acute PCI, the setting is this: in an ST elevation MI or a high-risk non-ST elevation acute coronary syndrome, PCI is the preferred choice. So they're all saying the same thing in that area. But what he said was that in stable angina, the PCI does not seem to have benefit when you're looking at redos or in terms of death. So in other words, many people have to have redos. So the question is doing the open surgery worth it, or is a redo really a bad thing? Because some people may say that a PCI redo is not that complicated. You go in a day or two, you're back out. So therefore, even though you did have a redo, which means that it's a failure, some people may not see that as a nuisance along the way. And then he continued on to talk about Syntax and the study, and basically how CABG was better than stenting, and that from there we have the Syntax score, which can then tell us who will go on to do well and who does not. And he gave us a reference about this online STS calculator. So if you wanted to calculate your patient's risk or your own personal risk in terms of the bypass, you can actually do that. And basically he was explaining some of the new innovations in terms of sternal locks, so that you can pull together the sternum, and kryptonite, which is this new glue that you can use to stick together your bones. And then Terence Yao came along and talked to us about stem cells. So basically there, what he was saying is that after transplants of female hearts into males, they saw that there were male cells in the heart, which meant that there's some cells coming from the outside going into the heart, and that was the thought of how come where are these cells coming from, and the thought is that it's from the bone marrow themselves. Transplantation is sort of the cure, I guess, for heart failure, but 500,000 congestive heart failures per year, but then only 200 are getting transplants, so we need to do something for the other folks. And so the thought is, can we take your own stem cells out, purify it on site, okay, which is what's happening at the Peter Munk Center, and then inject it back into the person, into the heart and into the infarcted areas, and then allowing those stem cells to take hold, and then you will have muscle cells and fibrocytes and all those other things being formed there. And the study basically included people that needed a bypass, so that means you're going to be opening them up, and then their left ventricular ejection fraction is between 25 and 45%. And then what you do is you do this procedure, and those are the types of people that they're looking at. And he gave us a hint in the future that you might have like X-Men, you know, these modified stem cells, these super powerful ones that could survive the toxic environment. Because remember, the heart died because the patient is inside a toxic environment. So can we modify the stem cells to make them survive better? And also the thought is that maybe using lasers to punch some holes into the myocardium and then injecting these things in may actually make the cells live, because you'll have pools of fluid that can collect in these tubing, and that might help keep the cells alive as well. In terms of safety and radiation, Ed told us all about radiation. So he's interesting statistic, 1987, 15% of the radiation exposure was from medical procedures, whereas in 2009 it's jumped up to 48%, and half of that is from CT scans. And fluoroscopy went from 3% to 14%. So there is an increased usage of radiation. Then he went through nicely sort of all the different ways to measure things. So the absorbed dose, so if you see something in grays, that's an actual measurement of how much radiation is going in. Equivalent dose, you now take that measurement and you adjust it for the type of radiation. So is it gamma radiation, so on and so forth. And the effective dose, you take that number and then you adjust it for the tissue sensitivity. So if I'm shining it on your head or your testicles or whatever I'm trying to destroy, that might be a little bit different. And then basically, once you convert it away from your original gray, you call them both sieverts. So therefore, that's a little confusing, because one of them is just telling you what the radiation type is. The other one is actually telling you radiation type and tissue sensitivity. And then the risk of radiation and cancer is now another adjustment, and that will give you a risk assessment of how likely you're going to cause cancer. So these are all the fudge factors that go in. And basically his commentary is that we don't know anything about low end. So below 100 millisieverts, we're not sure what the risk is. There might be no risk when you're down in the lower end. So that's why we can get away with some of these scans. However, if you do want to calculate risk, and many people have done that, somewhere around 4 to 10% cancer per sievert. And the other one, if you're a fetus, then it's a 20% increase per sievert, just because they have more cells in the mitotic phase, so you may damage some DNA along there. He thinks that it's not linear, but everybody does the calculation as if it's linear, that there might be thresholds. So above this amount, then you get damage, but below that amount, maybe not. Or perhaps it's curvilinear going upward. And this thought that there is DNA repair centers, and it turns out there's some research that says during the day it's different how you repair your DNA. So there's periods of times where you can repair your DNA better. So I guess if you got radiated at that time, then that would be good. Try and figure out the appointment schedules that way. How's your DNA repair cycle? And then he said, basically, until we know more facts, which we may never know because you can't do experiments on people, just beware and be able to justify high-dose imaging modalities. For younger people, be careful, so babies and things like that, and track some of the exposure that we're actually looking at along the way. Then he tried to equate certain millisieverts to how many cigarette packages, but I don't think that's going to work. So imagine if I tell you 8 millisieverts is 2,664 cigarettes. I don't think anybody will take these X-ray tests if we use those terms. So that may not be the suggestion that we will take away. And then we had the renal denervation, which was hot in the press. And so the thought here is that for people that are resistant to all the drugs, so more than 3 medications that they're taking and they're not using it, then maybe they might have resistant hypertension. And the thought is, back in the 50s, if you did sympathectomies, you can actually do some good, but then you had all the problems because you're cutting all sorts of nerves there. And so the thought is, can we map and just burn around your renal artery? And so that's what they do. They map out and they burn from a catheter, and by doing that you can decrease the sympathetic tone going to your kidneys, and you can have drops of, I think, somewhere in the order of 32 millimeters of mercury, and so therefore you can actually treat and control these people. The future of that is, shall we expand it to more patients, in other words with milder disease, or with other kidney failure and diabetes patients, because there seems to be a connection between the sympathetic tone in the artery and insulin resistance. So there may be some future studies there. Then we jumped on into the cardiac screening kind of debate. So Sebastian basically told us that screening is when you have no symptoms and no signs. And the ideal test is that you should be able to do it early, you should detect something, and then you should be able to change the outcome. In other words, treat the patient so they don't get the disease. The downside is if the test is not good, you're going to have false positives and false negatives. So false positives, those people are going to get more tests that they don't normally need. And a false negative, we're going to think they're fine. We'll say, go ahead, jump off the cliff, you're not going to die, that kind of thing. And so therefore, there are problems on either way. And none of our tests are 100%. That's the problem. So what he said was that using the Framingham, you could separate into high, intermediate, low. If you're in the high-risk Framingham, you don't need any more tests. We already know what to do with you. If you're in the low risk, we probably know what to do with you as well. It's the intermediate gray zone that we have difficulty with. So if you are in the intermediate gray zone, then a coronary calcium score may be helpful, because if you have a very high coronary calcium score, then that would shift you up. So instead of being an intermediate, you may go into high risk, therefore you might do something different with them. And if you have a very good calcium score, then that might shift you into a lower risk, therefore we don't have to be so aggressive with you. The other category that might be helpful is if you're in the low risk but a very positive family history. So somebody in the family with disease that is less than age 60. So therefore that would qualify you as well as doing the calcium score. Ethnicity, there was no difference, so that was very nice, because we were worried the South Asians perhaps might have soft plaques that explode, therefore they might not have calcium scores to measure, okay? Isn't that a lovely thought, eh? But the problem is that even if you have a calcium score of 0, it doesn't mean that you don't have any plaque. It just means that you don't have calcium in the plaque. So therefore, there are still people that have those plaques that will explode. So that's the downside of the calcium score. So even zeros will go on to having events. About 17% of them continued on. Radiation is 2.3 millisieverts. So somewhere, if you do 100,000 people, you'll have 42 for, I think it was men, and 62 for women in terms of increased cancers. And you might find incidental nodules that you get all excited about and get patients worried about. So there is some downside of doing these types of screening tools. In terms of a symptomatic person, calcium score is useless, because it's not going to add any information to you. So it's not going to tell you not to treat them or to treat them, because they have symptoms already. CT angiograph, that was the one where he said it is not recommended for asymptomatic people. So therefore, we don't use CT angio for screening for that particular reason. Cardiac hybrid imaging, so this is the idea that can we put two types of imaging together. So normally we do an echo, where we do CT imaging or cardiac MR or nuclear imaging. So they're all separate, but they each give us a bit different piece of information. Some is about anatomy, some is about perfusion, some is about function. And so therefore, can we put two of the pieces together? That might give us better information. Angiograms only tell us about the lumen. The CT angio now starts telling us about the wall, and we can actually look better at it. But then if we put PET, for example, with CT, that might be interesting. So the PET will talk about perfusion. And if you can overlay the two things, then you'll have an idea what area of the muscle is damaged or at risk. And so therefore, you'll know whether that stenosis is significant or not significant. Because just because you see a stenosis doesn't mean that the blood flow is compromised. So therefore, you might have some better information with both of those together. And MR PET might be something that's coming, and it is coming to the Peter Munk Center. So I'm told that the funding and everything is there. So it's a matter of just, I guess, getting the space and digging things or whatever they have to do to set that up. And so therefore, these hybrid images will be useful for us to look at things. Then we went on to our electrical folks, so oral anticoagulation and atrial fibrillation. So atrial fibrillation accounts for 1 in 5 strokes. And they tend to be bigger strokes because you can get bigger clots in your atrium, and therefore you can have much larger strokes than in your neck. And that's why we have to pay attention. So there's 2 scores or 3 scores that we need to know. So the CHADS-2, basically just to remind you guys, so the C stands for congestive heart failure, H stands for hypertension, age over 75. The D stands for diabetes, and S is stroke/TIA, and it's worth 2 points. Everything else is worth 1 point. If you have a score of 0, you have a 1.9% per year, so it's not 0 risk, it's 1.9% per year of having a stroke. If you're a score of 6, then you're 18%. So you could see that there is a spreading of risk along the way. Anything above 2 needs oral anticoagulation. Anything that is below 2, you can think about aspirin or oral anticoagulation. But with 0 and 1, they said that we might be able to separate that better, so therefore we do CHADS VAS score, which now gives you a couple of extra things. So the extra things they said is that instead of age over 75, What about age over 65 as being also a risk factor? What about female being a risk factor? And what about if you had vascular disease? So if you have PAD somewhere else, you're still at higher risk. So we added in 3 more of these parameters, therefore you could separate out that lower risk people. So if you're over 2 on a CHADS, you're done. If you're 0 or 1, then you do a CHADS VAS just to see, are you really low risk, or are we just missing some of these other parameters, okay? But it's the same rule, so above 2 in either one, you're gonna get treated with oral anticoagulation. Just one point is that, because people ask always, when do you use aspirin, when do you use anticoagulation? This is just me talking, so nobody intelligent. So it turns out that in fast-flowing blood, okay, so fast-flowing blood in your carotid, it's the platelet that sticks first, okay? So platelet sticks first, and then the coagulation system comes on top of that. So therefore, antiplatelet therapy works better here and in your coronaries, in acute coronary syndrome. In slow-moving blood, it's the coagulation system that kicks in first. So therefore, when you have a DVT, it's the coagulation system that kicks in, not the platelets. So that's why we use anticoagulation when you have slow-moving blood. In atrial fibrillation, it's slow-moving blood because the atrium is shaking. So that's why anticoagulation always works better. So warfarin has beat out Plavix and aspirin together, and that has beat out aspirin alone. So if you keep that in mind, it's very easy why you use an antiplatelet and why you use anticoagulation. We do have some newer anticoagulation strategies. So dabigatran, which is a direct thrombin inhibitor, which blocks quite low on the cascade of making those the clot. And the only thing you have to remember about that is it's renally secreted. So if you have kidney failure or kidney problems, then you're going to accumulate the drug. So you have to keep an eye on creatinine, even though you don't have to monitor anything, but the creatinine you do have to monitor. Compared to warfarin, 150 twice a day, it was better than warfarin in terms of stroke and clot prevention. And bleeding rates were the same as warfarin at the higher dose. But at the 110 dose, the stroke prevention was the same, but the bleeding was less. So if you're more concerned about bleeding, you go with the lower dose. If you're more concerned about stroke, you go with the higher dose. Most patients say, I don't mind bleeding, I just don't want to have a stroke. So generally speaking, people will look at the higher dose. If you have renal issues, then we have to adjust the dose, obviously, because the kidneys cannot get rid of the drug. Then he told you to go and Google things, okay, in terms of the switch, how to switch people around. So either from warfarin to dabigatran, dabigatran back to warfarin, or heparin across. So there's information out there for you, as well as what to do for surgery, how many days you got to stop. And remember, it's based on your EGFR, okay? So that's all you have to remember. We will try and get those slides available for you, okay? So if you want to leave us in the green form, just write down, please email me slides and put down your email, like in writing that I could read maybe. Then we'll send it to you in that fashion. There are 2 other drugs, rivaroxaban and apixaban, which are 10A inhibitors, so they block a little higher up, and they have some data around them as well. For people with coronary artery disease, acute coronary syndrome, PCI, especially acute coronary syndrome, PCI, if their CHAD score is more than 2, now you need triple therapy, right? So now they need the antiplatelet because they either have a stent or they have a coronary disease, and they also need anticoagulation. They do have a higher bleeding rate, but unfortunately we can't help that. Drug-eluting stents are good for those people because, bare metal stents tend to be good for those people. Then you don't need to have them on dual antiplatelet for as long. So therefore, that may change some people's decision. Catheter ablation, I won't bore you with that. Atrial fibrillation is a symptomatic treatment. People feel bad when their heart goes crazy, so then we talk about rate and rhythm control. So rate control is beta blockers. Rhythm control we can do with drugs, antiarrhythmics, or ablation. The ablation data is very good, like in terms of helping that. They found that there are triggers around the pulmonary veins, so if we can go and zap the pulmonary veins and block off those signals coming into the atrium, then you will not have the atrial fibrillation. And so that's basically what they're doing. They're not perfect. If they miss an area, you can still get signals coming through. And the success rate is somewhere between 60 and 70%, and there are redos about 15 to 25%. So your patients need to know that they may have to go back in again. If you have long-standing atrial fibrillation, you may have more scars, therefore they don't do as well on the first go. So they tend to need more redos. And certainly the people that are at risk in terms of failure over 5 years, there's a 5 or 7% failure rate. And so the thought is that if you have high blood pressure, sleep apnea, valvular disease, cardiomyopathy, if you're an old person, or a long-standing atrial fibrillation, those are the people that will get into more trouble with that. And in terms of heart failure and atrial fibrillation, there's data that says that maybe we can do some good for those people because if the atrial fibrillation isn't there, the heart may be able to beat better. And then we talked all about, you know, the defibrillators and things. I'm glad he checked that. He sort of told us what that all means. It looks like alphabet soup. So basically he said that A pacemaker just is doing that. It's just pacing when, to stop it from going too slow. A defibrillator will send a high voltage shock to stop the ventricular tachycardia or VFib. And the cardiac resynchronization is basically trying to get things to beat properly so that everything should be squeezing towards the center as opposed to one squeezing and one leaving. That's kind of like when you're dating, right? You should be heading towards each other, okay? So that makes it a lot easier. So resynchronization, so the CRT can have a defibrillator, so that's the one with a D, or it can just have a P, which is just a pacemaker, okay? So that way you understand what the alphabet soup means. Bottom line is if you put in a defibrillator, people don't die of sudden death. So therefore, he said that there's death by drowning in heart failure and death by dropping. So therefore, the defibrillator will stop the death by dropping. And then the thought was, is that can we do the resynchronization? And so if you have a big, huge, ugly left bundle branch block, the muscle is not contracting at the right time. So one will contract before the other, so you're not squeezing anything out. So if we can resynchronize, that would be helpful. And he showed beautiful numbers like 40% reduction in events. And the thought is right now is that even in New York heart failure class 2, which isn't that symptomatic, if your ejection fraction is less than 30 and your QRS is wide, so above 150 milliseconds, then you should really be thinking about resynchronization. And if we do it earlier, we may actually save these people from getting worse over time. Rapid ventricular management, Kumar went through all that and basically said these people can be kept alive by the defibrillators that we've implanted, but the more shocks they get, the worse they do in the long run. And so therefore we need a way to decrease that. And this is where the catheter ablation kind of concept comes in. And then he talked about innovation at the Peter Munk Center. So originally you map it from the outside, which is quite slow, and then now he showed you that array where you just put out this net, and that net will pick up the whole map inside the ventricle. So very quick acquisition of data as to where the spots are actually causing the ventricular tachycardia. And then what you do is you need to deliver energy, so now you put a probe in and you shoot the pulses in. But unfortunately, the muscle may be thick, so therefore what they did was they innovated with a catheter on one side, catheter on the other side, and then you fire the electricity or the pulses through the two catheters. And then finally, who cares about your service if people can't get there? And so that's why they've innovated in terms of the urgent VT service. So therefore, it's sort of a complete system as you're looking through. And I think that's the sort of the thinking, is that we would like to have nice, complete systems when we're sending our patients into this. And I guess that was the whole idea of the Peter Munk Cardiac Center, is that everybody is working together. So you saw radiologists, you saw cardiologists, you saw vascular surgeons, you saw all the people coming together, and you even saw the electricians getting together. And so the idea is that everybody's working together so that my strengths, their strengths, we put them together, and the benefit will be to that of the patient. And I think that was the original purpose of the Peter Munk Cardiac Center when it was created, and it's very nice to see that that's actually working as we move forward. So that's all I have to say, but, okay, so now we have an announcement. Would you guys like to come to one of these things again next year? How many people would like to come to this next year? Okay, so Narinder, please come up and let us know if we're gonna have one next year. Is it, oh, he gave it away. Okay, all right, go.
Firstly, you know what, if we got Peter to summarize all the talks, we could have this symposium in probably half an hour. What do you think? Okay. Terrific. Thank you very much, Peter. And thank each and every one of you for staying. I think the faculty did a tremendous job. I really enjoyed it, and I heard from some of you that you feel it's getting better and better every year. And that's, a lot of it's due to your comments and your feedback. And as Peter mentioned, we are trying to illustrate the integrative approach, multidisciplinary work. Everything you saw here could not happen without our nurses and our technologists, anaesthetists, and everybody else who works with us, and our management staff who allow us to operate in a financial envelope. So it's very important to although you saw all the physicians up here, that's not necessarily always going to be just the physicians up here. I mean, in future programs, we will look at having some of our allied health staff up here as well. But yes, we are at the same time next year, sort of, 25th and 26th. So if you like what you saw, please put it in your diary and tell your colleagues. If you didn't like what you see, please put it in your comments, and we'll address those issues. But with that, I'd like to thank everybody, and I would like to say that Barry has been a tremendous advocate and a supporter of this symposium, and he's always written the check when we've needed it, so that's been terrific, and we've had plenty of support from our industry partners. So thank you very much, and have a safe journey home. Thank you.